So much for joining us for our first of many webinars discussing epigenetic aging. Here today we have Dr. Dan Stickler, based in Austin, Texas, who runs Aperion and several other businesses in this field. Great, thanks for hopping on, Dr. Stickler.
Glad to be here.
Yeah, so we've worked together a lot in the past, but for everyone who's watching, can you give just a little bit of an introduction to some of your background?
I was a general vascular surgeon and just became very disenchanted with the whole disease model of health, and started really diving into more of the complex system approach to health, and looking at health as a dynamic progression rather than disease versus non-disease. You know, how can we continue to be better in aspects of that? And we developed our medical model off of that over the last 15, 16 years, and then developed a training academy where we've trained over 400 coaches worldwide in doing our model. Those are physicians, chiropractors, naturopaths, health coaches, dietitians. So across the board, it's something people have been looking for, and it's something that you and I have talked about quite a bit in looking at health from that dynamic perspective and optimizing health rather than just looking at, you know, are you diseased or non-diseased.
I know that one of the ways that I started following you was through some of your work on functional genomics, using sort of the genome to tell you a little bit more about what you should be doing. I know that a lot of people can get frustrated with some genomic work because they're not sure how to use it. What's the end result, and how do I affect this? And you've done a lot more in that functional realm. Can you talk a little bit about your experience there, how you got to that field, and where you're doing it now?
I mean, we got into genetics back in 2007, and it wasn't something I learned in medical school back in the early 90s. It was a whole different world. We were looking at polymorphisms, which, even now, I think 90% of the people out there using polymorphisms have no idea what they're looking at with these. I mean, they'll call them mutations, and it doesn't quantify as a mutation in any sense of it when you understand what you're looking at. And for me, the molecule of DNA is probably the most intelligent and fascinating thing I have ever encountered. I mean, the complexity of it and the intelligence of it, it just blows me away. And I know it does you too. I mean, as you've gotten more and more into the epigenetics realm, but in genetics, what we came to understand early on was you can't use absolutes of genetics. I mean, genetics is it's another biometric that you use just like lab work. And there's not a linear approach of if you have X, then you're going to have Y. It doesn't work that way, especially when we're talking about polymorphisms, which is what all these testing companies essentially do. Is 23andMe, Ancestry, our genetic test, it's all looking at polymorphisms. It's not looking necessarily at this entire genome of 3 billion base pairs, which 99.5% of we really don't have any idea what to do with. So it's at less than 0.5% that all of us are looking at. And in the face of that, what we came to discover, and you as well, is the epigenetics is probably trumping genetics. We look at genetics as the blueprint, but that's all it is this is the base from what we build off of. And the epigenetics is what determines how all of these things are expressed. And so there's been a shift into epigenetics, and it's such a new field that, at Stanford, they've had one course for the last 3 years that's been taught in epigenetics. And I've had the pleasure of being a guest lecturer every semester to talk about the clinical applications of genetics and epigenetics. But it surprises me how little this is actually getting out there, because epigenetics is truly, from what we know at this point, and this may change, but epigenetics is really where we want to focus our attention.
I think that we're all really excited for it as a biomarker for a lot of different reasons, especially on the improvements it makes on the DNA. And before we get into that, before I ask you a little bit sort of your personal background with the biomarker, one of the things that I think you do in your clinic more than almost anyone else is look at a variety of biomarkers. I know that you've previously tested things like glycan age. I know you've done some telomere assessments. I know you do even things like skin glycosylation and some really abstract biomarkers. Can you talk a little bit about some of the other ones that you take in clinic and some of the things that you see value in?
Right now, we look at information. I mean, the more data we have, the more accurate we can get with guiding people and understanding where they are in their moment. I mean, aging right now is such a hot area. I mean, there's researchers all over the world trying to find the biomarker that's going to tell us, how old we are biologically. But, you know, that to me is not the most relevant aspect of it. What is relevant is how a marker of how healthy we are. It doesn't matter to compare. If somebody said, "Oh, how is your biologic age relative to other 54-year-olds?" I'm going, I don't really care. I want to be compared to a 25-year-old if I'm going to be compared to somebody. But telling me that I'm better than 20-30% of 54-year-olds means absolutely nothing to me. I want to know how healthy I am. So we look at EKG or EEG patterns in the brain, and we can see aging parameters in there. We look at VO2 max, and we can see aging parameters in that. We look at heart rate variability and breath rate variability. We look at CO2. We look at, like you said, glycan age. We look at skin glycosylation. We look at lab markers. We look at epigenetics as one of the most important right now. But what's going to happen is the more of these we gather, the more accurate we're going to be with assessing how healthy that human system is and how far from that I guess that cutoff of functionality occurs. People will tell you, it's not about how old you can live; it's about how functional you can be as you age. And if you said, "How old do you want to live to?" and somebody said, "Well, I want to live to 120," it's an irrelevant marker, because if once you reach 119, you've got the health of a 60-year-old. You don't want to say, okay, well, I'm ready to die now. And if you get to 90 and you've got the health of a 100-year-old, you may not be willing to move forward with that. So I think these markers are giving us better ideas of how we're doing and how we can change it, more importantly. It's irrelevant to say, okay, well, based on your genetics, you're going to be, disabled at this age and dead probably by this age. Well, that can't be there. It's a dynamic, and how can we change that and make that into a more optimized life?
I think that one of the things I want to stress even then is where this field might be able to go. I know that we always talk about data collection, and one of the really good things about the epigenetic data collection is that there are so many different locations on the genome to look for methylation that you can get really specific readings and correlate them to other metrics. And so that's one of the things that I'm excited to work with you on, is gathering all those other biometrics that you're already doing and see if we can consolidate them into sort of one predictive test, one that might be able to predict VO2 max, for instance, or skin glycosylation, all by looking at the epigenetic changes. I think that there's a lot of value in doing that. I think that it's very clear that these composite biomarkers are going to be the best at predicting physiological function as we age, and hopefully we'll be able to even make a composite biomarker that is trained from all these other biomarkers, specifically for methylation changes, and hopefully we'll have that with a lot of the data we're collecting, in the near future. So with some really good predictive value. And so I think that, yeah, without getting too deep into it, just sort of taking a step back, can you talk a little bit about some of sort of your exploration into this epigenetic age measurement and why you think it really holds value for your clinic and for the future?
Epigenetic age, we started doing, probably about 4 or 5 years ago, I think. I can't remember when Epi-Age came out with the Horvath, the initial or rendition of the initial Horvath clock. Which was fascinating to me. And at that time, most of the thinking was that the accumulation of these methylation marks on the DNA was a one-way timeline. So as we age, we would accumulate these, and it was just a difference of how fast we accumulated them. And then September of last year was mind-blowing for people, even though you and I knew that this was something that was happening. But it's kind of like the 100th monkey, I say, because you have all these people that are saying this is possible, but there's not enough of them saying it. And then I think with Sinclair's book coming out and the Horvath Fahey study coming out in September, I mean, they both came at the same time. And you talk about the perfect storm for the 100th monkey, where all of a sudden the worldview changes. We can potentially reverse age. We can set the clock back through different inputs into the system. And this was really, it was, I guess, from a published standpoint, it's really the first study that showed that the epigenetic clock was not one way, and that we actually had control, that we could shift it back. Now we're still, I mean, we're still babies in this field, and we're learning this. And this is why it's so important for companies like TruDiagnostics. And it's why I'm so excited to be part of this, is that this is where we learn this. And we are taking these baby steps for some mammoth jumps, and the speed we're doing this is accelerating. So we're reaching that singularity point where all this is coming together, and you want to be on that leading edge to know, you know, this is what's happening, and this is how we can change it.
Exactly. And I think that, you know, one of the questions that just like functional genomics is, hey, you get this reading and then trying to figure out what to do with it. And I know that right now there's not a lot of literature in the area, but as someone who looks at so many different biomarkers, what are some of your favorite therapies to use just for improving health and improving the aging process? What do you typically do with your patients, and what does that workup involve?
And this is all individualized. You know, this is something that's really important to emphasize. Everybody, you have to look at in the context of who they are. I mean, that's why, you know, you see so many varied research studies that will say, oh, well, fish oil is good for you, and the other study says fish oil is bad for you. And they come out in the same week. You know, that makes no sense. And it's because they're looking at a very uniform population, or they're classifying it as a uniform population, that everybody's the same in this group. And as we know, every individual is different. Even identical twins, their context creates a completely different outcome over a lifetime. And so even if we had a monoclonal line of people, if we didn't control for the lifestyle 100%, these studies are only guidelines for things to look at. Now, epigenetics is a little different story, because epigenetics, fortunately, we can look at the changes that are occurring in the cellular level with a lot of this research. So for me, I mean, we will do varied interventions based on what we see in the studies. So we use things like, we'll use like rapamycin. We'll use things like dasatinib and quercetin. You know, we're looking at things that the literature is suggesting are going to have a benefit. So we're going to look at, you know, reducing senescent cell load, inhibiting mTOR, and looking at the plus minuses of each of these. We use neuropeptides. We use peptides that boost mitochondrial health. We use skin peptides that are going to rejuvenate skin. We use brainwave stimulation, and we use medications such as ketamine to boost neural connections and reverse age the brain. Now, this is all in that realm of, you know, these are theory based on data that we're seeing in the literature, but it doesn't mean anything for you as an individual unless we know that we're actually seeing the positive changes that are occurring. So not only is it important to have this arsenal of interventions that can help age reverse, but we've also got to have the testing that can tell us whether this is working or not. You know, are we seeing the positive changes in the brainwave patterns? Are we seeing markers, and maybe not direct markers, because we're not going to, you know, do biopsies on everybody's organ to determine whether their senescent cell load is reduced. But we can use stand-in markers such as the lab work or the epigenetic age, or even wearable biometrics to see if an intervention is actually creating a more youthful expression in the personal biometric data.
And I think that that's one thing that is definitely worth emphasizing. You know, I think we've on several other podcasts talked about this sort of 60-40 rule, where they say that 60% of your epigenetics is changeable and 40% is heritable, which allows you to sort of take back that control. But it also allows for this personalized, individualized medicine, where you're looking at one value and seeing how intervention changes that value for a particular person. And I think that that's one of the other big values of this epigenetic testing, is that it's changeable, it's personalized, and the personalized interventions also are related to outcomes. So you can see how some of this treatment is affecting risk in the long run, which is something you haven't been able to do with a lot of other biomarkers that are less correlated to outcome measures, like most chronic diseases like cardiovascular disease, diabetes, and even cancer. And so, I definitely love you mentioning that it is a personalized approach, and that's how you view it for every patient, is looking at how things begin and how things end.
I think it's really important for people to understand that this isn't something you do alone either. And I don't think this is, and what I mean by that is, you don't get a test and then you say, okay, this is what I'm going to do with the test. I mean, you can get suggestions on that. I mean, even our genetic report, I mean, we're not hugely excited about offering it as a direct to consumer. And in fact, when we do offer it that way, it's going to come with the caveat that, this is probability data, and the way that you're going to actually impact this is working with someone who understands, like epigenetics. You've got to understand lifestyle epigenetics to understand how that works. It doesn't have to be a physician. I mean, there are coaches out there that are excellent for working with lifestyle. And I can tell you, 95% of all the stuff that we do for age reversal is lifestyle patterns. It doesn't require these medical treatments. Now, as we get into more advanced stuff, some of these medical treatments are coming on board, but having a coach that truly understands the epigenetic impacts, and this is one of the things we're going to be working with you guys, is identifying what lifestyle patterns are actually having that greatest impact on the change in epigenetic expression and emergence of new traits that are occurring in these individuals.
And I should mention as well that to date, there's only been that one interventional trial that you and I both know, the TRIM trial. But I think there's some coming out which are looking at sort of 8-week gaps focused on nutrition and supplementation and lifestyle interventions, which are having similarly positive effects. And so I think that backs up the idea that lifestyle and diet are fundamental, and that can be helped by a wide variety of different sort of coaches or practitioners to sort of help everyone on their journey. Generally, in terms of sort of diet and supplementation, is there something that you often sort of implement as a starter for most of your patients?
If you were to say, what's a general approach, and this is based on the North American population, European population, most people will thrive best on a kind of a fish-based Mediterranean diet. I mean, that's just what we've seen from not only our genetic analyses, but in our intervention studies. And there are multiple reasons for that. I mean, this is why it's important to get your genetics, because you can look at ancestrally, what environment were your ancestors exposed to over time, and what genes did you select from those polymorphisms that give you survival benefits. And this is why we say there is a gene-based diet that is a probability diet for most people, where we can look. You've inherited these polymorphisms, so you're designed to thrive in this environment. So this is the environment we're going to try to replicate for you. And the Mediterranean diet is a very common one. I mean, you take an Inuit Eskimo, somebody who's had a heritage of that, and then all of a sudden you move them into a Western environment. Their genetics have been selected for a diet that's high in fat. Probably 80% fat, and their genetics are designed to thrive in that environment. But then we move them into a more starchy or carbohydrate-based diet, they're going to get heart disease. The opposite may be true for somebody who has ancestry from Southeast Asia, where they were predominantly starch-based, or Africa, where predominantly starch-based, and you put them on a high-fat diet, and it's not going to work. So there's no perfect human diet, but there is a high probability of identifying a diet that's going to help you to thrive. And this applies across the board. I mean, it's not only diet, but it's exercise patterns, it's sleep patterns, it's supplementation patterns. So these can all be kind of identified with the genetics. Then we can use epigenetics to start to fine tune that even further, and create a custom plan that is designed around you as an individual, not as this collective of, you go out and buy the starch diet book, or the keto book, or the vegetarian book. Those are random, and you've got to be able to understand whether those are really impacting the system in a positive way or not.
And I think that we, with our TruAge test, try and add a little bit more light to that as well with some of our reporting. We talk in one of our reports, we talk about the Mediterranean diet. It's one of the very, very few diets which has actually been, I should say, studied to have a positive effect on this epigenetic aging rate in most populations. But we even dive into some of those other predispositions. We talk about things like the Latino or the Mexican paradox, where they have higher inflammatory markers, but actually lower epigenetic age over time. And so it speaks exactly, I think, to what you're saying, where it needs to be personalized to some of the ancestry and genetic components, but also, sort of looking at the epigenetic components as a way to get some real-time feedback in terms of interventions and seeing how, along with other biomarkers, how everything is working. And so I appreciate your time today. One just wrap-up question is where do you think, I know that you're involved in a lot of sort of cutting-edge medicine across the board. Where do you think that this epigenetic testing will end up in the future, in maybe 10 years from now?
It's hard to say because, this is going to be something people are going to have to learn. This isn't something that, you can offer out for everybody direct to consumer and think that they're going to have actionable, they'll have some insights, but the true action occurs from learning from people who understand this. And, this is what we've talked about, is creating training programs through TruDiagnostics that can educate people, that can be coaches out there, that can deliver this in a way that's more actionable than just a report that you read through and say, okay, I should be doing this, I should be doing this. You've got to have that person who understands it, one, and two, the person who can guide you with selecting metrics that you can use to monitor it over time. This is where things are going. And I don't think physicians are going to be in the position to do that. They're not even teaching single nucleotide polymorphisms in medical school. So to think that they're going to go into teaching epigenetics when you've only got one class at Stanford right now, they're getting ready to launch a second one, and it's not even in the medical school. I don't see this. There's too much information in medicine now. I look back at what I learned in the late 80s, early 90s in medical school, and it's overwhelming that I use very little of what I learned then, and I'm using a ton of what I've learned in the last couple of years as completely new data. So trying to keep up with that, I spend 2 hours every morning reading studies just to stay current with it. So trying to catch up is not going to be the most feasible thing to do for us. So I think we're going to see a whole shift and change in the way health and wellness is being delivered in our society. And it's exciting for me. I think it's going to be a very positive change overall.
Well, good. And so for anyone who is interested in Aperion training, because I know you do a lot of this training, breaking down both the functional genomics and epigenetics, what's the best way to get involved?
Well, you can go to aperion.academy. It's not a .com, it's just a .academy. And it talks about our training program. We're in the process of completely revamping it right now, and hopefully working with you guys to go a little bit more in depth with the epigenetic piece. That's essentially what we train, is genetics and epigenetics and complex systems in there. But I think a deep dive, now that we've got the awesome testing that you guys have, actually creating training around utilizing this is so exciting for us. So we're pumped to be excited to be involved with this.
Well, thank you so much for the time, Dr. Stickler. Look forward to having you on for future discussions when we talk about what interventions seem to be working at a larger scale and how they relate to other areas and these other biometrics. So look forward to having you back, and thanks so much again.
Yeah, for sure.
Thanks.